Thank you. I'll try to get my slide up right now. Can you guys see my slides okay?
Yes.
Perfect. All right. Well, welcome everybody. I'm David Weissman. I'm from the National Institute for Occupational Safety and Health here in Morgantown. We're part of CDC. Here are my disclosures. And NIOSH, just by way of introduction, for those of you that don't know us, we're part of CDC in the Department of Health and Human Services. We do research and make recommendations. A lot of people often confuse us with MSHA and OSHA. They make regulations and enforce them. They're in the Department of Labor, so we're a bit different. So here are the learning objectives for today. To recognize the role of work exposures in causing respiratory diseases, to understand the importance of asking adults with new onset or worsening asthma about relationships to work exposures, to recognize that risk exposures for fatal asthma in general also apply to occupational asthma, to learn a bit about the types of work-related asthma, and to learn about the importance of eliminating exposure to agents that cause occupational asthma. So we'll start out with a bit of an introduction, then we'll talk about two cases that I've encountered through my work at NASH over the years. One in a truck bedliner applicator who was exposed to isocyanates, and one that we recently encountered in a cannabis production worker in Massachusetts. Then I'll talk a little bit about work-related asthma in general, and then we'll finish up. So work is a really important risk factor for respiratory disease, and that's been recognized since antiquity. And it makes sense because for those of us who work, we spend half our waking hours at work. And when you're at work, depending on what you do, you breathe in different inhalant exposures. So if you work in a chemical plant or a coal mine, or if you work in trucking or in construction, there are different dusts and fumes and chemicals you breathe in, and that affects your respiratory health. And work is also a social determinant of health because it's not just about what you breathe in at work, it's also about the other impacts that work has on your life. For most of us, our health insurance is tied to our work. And so the quality of your health insurance, or if you don't work, if you don't have health insurance, that modifies the effect of your disease. Your nutrition, your lifestyle, those things are affected by your work, the disposable income that you have. So work affects respiratory health in many ways, both directly and indirectly. And work at the population level, at the epidemiologic level, is an important determinant of respiratory disease. So you see yellow highlighted here. In epidemiologic studies, it's been estimated that about 16% of asthma in adults is attributable to what they do for a living, to their work. And you can see a number of other diseases listed here with their attributable fractions. So, for example, pneumoconiosis, like asbestosis or silicosis or coal workers pneumoconiosis, you only get that if you have certain jobs. And so that's 100% attributable. And things like asthma, where things in your daily life can cause it, but also your work can cause it. It's not 100%, but 16% is still pretty substantial. Even though work is an important determinant of asthma in adults, people frequently don't think about it or ask questions about it. So this was a study that was done in people who presented with adult onset asthma, new adult onset asthma. And the investigators went back and looked at the medical records to see if people were asked about what they did for a living. And as you can see here in yellow, when they looked at the charts, they could tell from the charts that in about 75% of the charts, employment status was recorded. And employment status, whether you work or not, that I guess that's important for administrative and billing purposes. But in terms of looking at exposures, only about 11% were questioned about exposures at work, only about 5% about their occupational duties. So frequently, even when it's clinically indicated, people don't get asked about exposures at work in their asthma. So with that introduction, we'll talk about these two cases, which I think are both illustrative. So this first case is a 45-year-old man who died of acute asthma shortly after spraying isocyanate-based truck bed liner onto the floor and up the sides of a cargo van. Isocyanate, it's a small chemical, it's a cross-linker. It can bind to proteins in your body and create new antigens that people can become sensitive to. So in any event, this truck bed liner that he was spraying was a two-component system that had a type of isocyanate, MDI, and polyether polyoil, which when mixed form polyurethane. A lot of polyurethane is cross-linked with isocyanates. So he would spray this, and you can see a picture of a worker here with a truck surrounded by that curtain, spraying that bed liner. When you enclose a process, you actually concentrate the chemical in the area where it's enclosed. So there he is doing that. The victim had performed this task for 11 months. 7 months prior, he had a episode of acute dyspnea after exposure to chemicals at work that required treatment with oral prednisone and a short-acting beta-2 agonist or SABA inhaler. He had a 10-year history of asthma, currently treated only with that short-acting beta agonist inhaler. The medical examiner's finding was asthmatic reaction due to inhalation of chemicals. He had a kind of a complicated autopsy that showed findings of asthma, but also diffuse pulmonary emphysema and numerous macrophages in the peribronchial alveoli, and heavy anthracosis. So here's another shot of where the worker applied the truck bed liner. You can see the curtain that he would pull around the truck and where he would spray. And there's the exit door you can see there. And here's a schematic. And, kind of what happened was he was spraying the truck bed liner. I don't know if you can see my arrow. Can you guys see my arrow? Okay. So he was spraying over here and apparently what happened was he developed symptoms and he walked out the door over here. He had an airline respirator that he unhooked over here. And then he walked over to the front of the shop. Here's the reception area, and he collapsed. And he was found by a coworker, and unfortunately, too late to save him. So here are some of the factors that are associated with increased risk of asthma-related death. History of fatal or near-fatal asthma requiring intubation and mechanical ventilation. Hospitalization or emergency care visit for asthma in the past year, and he had that acute episode. Currently using or having recently stopped using oral corticosteroids, which are a marker of event severity, and he had that. He wasn't currently using inhaled corticosteroids. His treatment, isn't really consistent with what we currently do for asthma treatment, just being on a short-acting beta agonist. At the time, it might have been okay, but currently we wouldn't do that. Overuse of short-acting beta agonists, especially use of more than one canister per month. Poor adherence with inhaled corticosteroids. And then you can read the others, including severe comorbidities. And on the autopsy, he did have emphysema, which may have contributed to his death. Here's the second case. And this is fatal occupational asthma in a cannabis production worker. So this was a 27-year-old woman. In January 2016, she had had an evaluation for chronic cough, and she had normal pre and post bronchodilator spirometry. She was not diagnosed with asthma at that time. In May 21, she got a job working at a cannabis production facility. And by late July, early August of 21, she had an episode that was thought to be COVID-19. But when she went in for her physical exam, bilateral diffuse wheezing was noted, and she wasn't treated or diagnosed anything for that. In September, October 2021, she had onset of work-associated rhinitis, cough, and dyspnea, as reported by her mom and her coworkers. And those were worse when she was around grinding of cannabis. About that time, she switched from her initial job, which was really kind of an inspection job where she would go around the plant, counting products and observing things, to a job where she was actually involved in grinding the cannabis and making cannabis cigarettes. And we'll talk a little bit more about that. But shortly after going into that job, she had an attack that caused her to need to be transported from work to the emergency department for dyspnea, where she had bilateral wheezing. She had symptoms that improved with an albuterol neb, and she was prescribed a 5-day course of prednisone, cetirizine, and an albuterol inhaler. And she really didn't have specialty follow-up after that. At any rate, in a few months after that, in January 22, she had status asthmaticus at work, resulting in cardiopulmonary arrest. She was transported and admitted to the ICU, where she had anoxic brain injury and ultimately was removed from life support due to her anoxic brain injury and brain death. So here are some of the machines that she worked with. Here's the cannabis grinder, where you would put the buds in this rotating drum here, and it would be ground up, and the ground material would drop down into this box down below. This ground up material would go into this shaker box, which was used for filling the cigarettes. So here you can see the ground material, and here you can see each of the little round cylinders here that are used for filling the cigarettes. And so, as you can imagine, grinding in the shaker box, this is very dusty and results in a lot of cannabis dust exposure. And so here are some of the inhalation exposures that are associated with cannabis production. And this is a growing industry in the US, and it's growing in West Virginia as well as the rest of the country. So as you can imagine, organic dust, like we talked about, the dust can have fungi and mycotoxins in it, bacteria and endotoxin, insects and mites that might be affecting the product. The product can also include allergens. There are allergens in cannabis that can induce sensitivity in certain people, so people can develop cannabis allergies. Also, you can have various chemicals and irritant gases and vapors that people are exposed to in cannabis production. And cannabis production exposures of the types that I talked about can have a range of potential respiratory and skin effects. So it can cause allergic rhinosinusitis, allergens just like any other plant allergen. It can cause effects on the lower airway. We'll talk about irritant-induced asthma and sensitizer-induced asthma in just a bit. Bisonosis is a disease caused by exposure to agricultural dusts that have endotoxin in them, can cause COPD. And these other diseases, hypersensitivity pneumonitis, can also cause skin disease, irritant contact dermatitis, and sensitizer-induced contact dermatitis from working with the materials. So a bit about work-related asthma overall. So work-related asthma can be divided into two things. It can be divided into work-exacerbated asthma, where somebody has pre-existing asthma before they have a work exposure, and the exposures at work make that pre-existing asthma worse. And this is present in about almost 22% of adults with asthma can experience exacerbations because of things they're exposed to at work. And hey, this can even be, doesn't have to be an industrial environment. It could be a non-industrial environment. Somebody working in an office and somebody with strong perfume next to them sets them off, or something like that. And then there's occupational asthma. Occupational asthma is new onset asthma caused by exposures at work. And that in turn can be subdivided into two types. You can have sensitizer-induced asthma, where somebody becomes allergic to something at work. So, for example, in healthcare, we had the example of latex allergy causing new onset allergy, new onset rhinitis and asthma in people. There was a huge epidemic of it some years back. And also irritant induced is another type of new onset work-related asthma, where you can have reactive airways dysfunction syndrome, which is caused by a large exposure to an irritant, like an irritant gas, or you can have chronic low-level irritant exposure that can eventually result in asthma. So, for example, somebody working with chlorine bleach a lot and over time recurring irritant can eventually lead to asthma. Here's some examples of agents that can cause sensitizer-induced asthma. We often see at universities, we see people exposed to laboratory animals, and so dander from lab animals, mice, and urine from animals, so mice, rats. You can be exposed to animal allergens, develop allergy from that. Flour-related allergens, so baker's asthma. Natural rubber latex I touched on, detergent enzymes. And then there are low molecular weight agents that can cause occupational asthma. And we talked a little, and these are usually reactive agents that can bind to proteins. So if you breathe them in or you get them on your skin, they can bind to proteins, create new antigens. People can become sensitized to that. So in addition to these isocyanates, anhydrides, Western red cedar dust, metal dust and salts like platinum, nickel, cobalt, and so on. This is a very busy slide, but you can see here a column for occupational asthma and a column for work-exacerbated asthma. And this is surveillance data from states listing the many agents that were encountered that can cause either occupational asthma or work-exacerbated asthma. And the main thing I want you to carry away from this is there are a lot of exposures at work that can either cause asthma or take pre-existing asthma and exacerbate it. Here's a review of work-related asthma mortality from Michigan that was published from 2003 to 2023. Over those 21 years, there were 13 deaths, ages 19 to 77, who had asthma for 1 to 37 years. And these are the agents that caused new onset asthma, leading to death in that experience. So isocyanates in 5, including this one case that I presented to you of the truck bedliner worker, molding release spray, pickle processing, which was an irritant exposure, welding fumes, and then work aggravated asthma, work exacerbated asthma. And here are the listing of things. And one of them was someone that was exposed to cigarette smoke in a bar. So these exposures at work can lead to pretty severe death. Low rate here, 132 deaths in about 860,000 individuals over that time. So they estimated the rate of about 0.015% per year with increased risk with increasing age, women more than men, blacks more than whites. Here's some other reports of work-related asthma deaths. This report identified 11 deaths in the literature from 1958 to 2002. And here the range again, isocyanates pop up, and chemical exposure, green coffee dust, flour, gum arabic, shark cartilage powder. Here are two deaths in the marijuana grow industry, including the one death that I presented to you earlier. Five deaths in California from 1993 to 2025. And again, you can see the list here. This also included a death in someone packing cannabis. So how do you diagnose work-related asthma? The first step is to diagnose asthma, is to make sure the person has asthma. And you diagnose asthma in the conventional way, history, physical, appropriate medical testing to see if they have airways instability, either bronchodilator response or methacholine challenge. And then if you diagnose asthma, new onset asthma, or if you see worsening asthma in an adult, it's really important to ask about potential relations to work. So ask questions like, did your asthma symptoms start at your current workplace or a recent workplace? Do your symptoms get worse at work? Do your symptoms get better on days off from work or from holidays? And these are really useful screening questions. They're not 100%. You don't catch everybody with a work trigger because some people, after they're exposed at work for a while, they can have issues all the time, even when they're away from work. But these are still useful questions to ask. And then pulmonary function testing can help to show an association between asthma and work. So, for example, doing ambulatory peak flow monitoring, giving someone a peak flow meter, have them check their peak flow 4 times a day, have them do it. And then you can look and see if they have more instability at work than away from work. Also, another approach that's been taken is to do a baseline methacholine challenge and see if the airways instability gets better after somebody's away from work for 2 weeks. Another thing that can be done is to evaluate for specific IgE response to workplace sensitizers, just like doing allergy skin tests for normal allergens. If you have a skin testing agent or a blood test for the relevant allergen at work, that can be useful. For example, flour in someone who works in a bakery. Often you don't have those kinds of tests available, though. In other countries, specific allergen challenges sometimes done where somebody can simulate what they do at work, except in a lab, and follow their lung function and see what the response is. That's not much done in the US. If you diagnose work-related asthma, there are steps you can take in prevention, both to help the specific worker and to help their coworkers. So if you diagnose someone, secondary prevention would be reducing their exposure or eliminating their exposure to prevent disease progression to worsening disease. So that's how you can help individuals. If you're able to feed back to the workplace, and if there's an exposure that's uncontrolled that affected the individual, it might also affect other individuals. So, in situations where you're able to contact the workplace and address those exposure in the workplace, you can do primary prevention and protect others by preventing sensitization and development of disease in coworkers. So, for example, in the cannabis worker, where it was a very dusty workplace, measures to control dust in that workplace, it might have not only helped that individual worker, but their coworkers too. We use the hierarchy of controls as an approach to controlling exposures not only to asthmagens, but other agents in workplaces. And this inverted pyramid shows the different interventions that can be done, both from the most effective to the least effective. So, for example, if you can eliminate a hazard from the workplace, that's the most effective way. Can you eliminate it, or can you substitute something that's less hazardous? And often that can be done. So in the case of latex allergy, we were able to substitute non-allergic substitutes and helping not only the individuals who are affected, but also other folks. Engineering controls are another way to control hazards. So can you isolate the process? Can you use ventilation or local exhaust ventilation to carry the contaminant away? Administrative controls, only allowing people who need to be exposed to the hazard to be exposed to the hazard, changing the way that people work to generate less hazard, and finally, personal protective equipment. And that's at the bottom of this hierarchy of controls. And the reason for that is that in order for personal protective equipment to be effective, the person has to wear it whenever it's required. They can't ever make a mistake. And each individual piece of equipment needs to work all the time when it's worn. And so you have to have a really well organized approach to PPE to make sure that PPE fits people and is functioning properly if you're going to rely on it. And really, PPE should be used as a backup. It really shouldn't be used as a primary method of prevention because if it fails, then there's no backup to it. It should be used as part of a layered approach that uses all of these different interventions. In terms of removing or reducing exposures in work-related asthma and their impact, there was a Cochrane report that looked at this. Cochrane reports look at the strength of evidence of different interventions, and they're pretty authoritative. This report found that both removal from exposure and reduction of exposure may improve asthma symptoms in people with work-related asthma compared to continued exposure, but only removal from exposure would improve lung function. And when removal from exposure was compared directly to reduction of exposure, the removal from exposure may improve symptoms and lung function more among patients exposed to low molecular weight agents, because that's where the most evidence was for isocyanates. Uh, Now, in terms of the benefits of removal from exposure, uh, if you remove somebody from exposure, that may also increase the risk of unemployment. It's one thing if you can change the work environment and get rid of the exposure and the person can keep working. But if you go and remove the person from that workplace, they may wind up unemployed. And care providers have to balance the potential clinical benefits of removal from exposure or reduction of exposure with potential detrimental effects of unemployment. Unemployment can have devastating health effects, once again, because people's income depends on it, their ability to eat, their ability to pay rent, their medical coverage. So sometimes you have to balance people's physical health and their economic health. Quick last word about population impacts of removing exposures. This is an example of a population effect. This was the removal of powdered natural rubber latex examination gloves from use in Germany and its effects on asthma and urticaria. And so here you see in Germany, they banned the use of powdered latex gloves. And here at this red line, you see over time the reduction in powdered natural latex glove use. And here you see in this blue line a little bit off, delayed in terms of latency, the decline in work-related asthma that followed, the decline in occupational asthma. And here you see the increase in use of non-powdered gloves. So as these allergenic gloves went away, this type of occupational asthma went away in the population. And the same graph for occupationally related urticaria, hives in workers. Natural rubber latex gloves going down, non-powdered gloves going up, and slightly out of phase here, urticaria coming down. So you benefit not only the individual, but also coworkers, the population, if you get rid of asthmagens in the workplace. So just a few words of conclusion. So work exposures cause or exacerbate asthma in a substantial portion of adults. Should ask adults with new onset or worsening asthma about association of their asthma with work. In occupational asthma, removal from exposure yields better medical outcomes than exposure reduction, but medical benefits have to be weighed against the potential harm of job loss. And then finally, risk factors for fatal asthma apply equally to work-related asthma. So I will stop there and I will try to figure out how to stop sharing and and answer any questions that folks have.